I'm Dr. Jam Kothari.
And I'm Dr. Sally Moore. And this is a Myeloma Minutes, a podcast for people affected by myeloma, patients, friends and family. Hello, Jam. Any news in the last few days?
Big problems. It's the end of the tax year.
Oh, yeah.
Got to pay my tax. See, we've gone from New Year's resolutions to you're paying your tax return. So, yeah, sorry for our non-UK listeners. The 31st of January is a stressful time for many people. I've paid my tax. I've contributed to society.
Well
and
done.
Now we can carry on and have another. I've been looking forward to this episode.
Yeah, it's been on our minds for ages, hasn't it? It's like, we must do soon. And finally, here we are. And the reason why we've been sent off track, and I'm not giving away what we're going to talk about yet, but the reason why we've been sent off track is I think all these nice appraisals coming through. It's just kind of like, oh God, we've got to cover this, we've got to cover that. But here we are today, Jam. And so what are we going to talk about today?
As Tracy Chapman said, I've got a fast car. I want a ticket to anywhere.
Irresistible.
Irresistible. So not automobiles. So we're going to talk about CAR-T therapy and CAR-T therapy for myeloma specifically. But I think we're going to talk about it a little bit generically first, Sally, and then hone into what it means for myeloma. There are approved CAR-T therapies for multiple myeloma. Some of our listeners may have had CAR-T therapy. It's certainly a fascinating and interesting field. The history of the field is also really, really interesting. It's an established therapy for a number of different types of hematological cancer, including types of high-grade lymphoma and types of leukemia. But yeah, myeloma, the CAR-T field is expanding rapidly. And a year in, Sally, we feel now is the right time to talk about it in some detail on the podcast.
Yeah, it absolutely is. And definitely, Jam, I totally agree. Many of our listeners actually may know someone who's had CAR T-cell therapy or have that coming up for them or have had it already. That's because this kind of therapy has actually been around for a while. As you say, in myeloma, but also in other, particularly types of blood cancer. So I guess if I was to think about CAR T-cell therapy, it's a way of describing a treatment which is helping the body recover from a cancer in a new way, in a very different way by harnessing the immune system. And that's why it's so exciting. And I'm sure you can remember the first time you heard about CARs. I definitely can. And I honestly was stunned. It seemed so remarkable. It comes so far that these new products, new ways of giving drugs beyond a tablet were actually going to come through to standard practice. It's been a remarkable journey for lots of patients and lots of illnesses.
Indeed, it has. It all comes from very clever scientists trying to understand how can we use our own immune system to fight cancer. And that's been really one of the key questions in understanding cancer. It's like, well, our body's so good at recognizing, a bug from a dodgy piece of chicken or tuberculosis or any other infection, and your immune system will get there and, in lots of situations, totally sort that out. But you can have areas of cancer, areas of cells multiplying in your body, and the immune system doesn't notice it or can't work in the same way. And certainly in many cancers, and especially types of blood cancer, certain cells called T cells, which are a type of white blood cell, are crucial to this process of looking at the immune system, what we call surveillance. And people thought, if we can understand these cells better, if we can do something to them, how can we make them something that can attack the cancer? If you can just tell us, what does CAR-T, stand for? And very sort of simplistically, how does it work?
The CAR, and it's so easy to remember, isn't it? It stands for chimeric antigen receptor. Now that's a bit of a mouthful, but what it's basically referring to is the fact that you're changing your T cell, this really important immune cell, so that it can recognise the myeloma cell in a different way. It has a receptor on it which latches onto the myeloma cell in a way that it wasn't able to do so before. That receptor wasn't there before. And in latching onto the myeloma cell, it can destroy it. But what needs to happen beforehand is you need to take these really important immune cells, these T cells, and make them express that receptor. And the way you do that is you take them out of a patient's body, you change their makeup through transfecting them, or a virus goes into them peculiarly and changes the makeup inside that T cell. And then you put that new T cell, that sort of rebooted T cell, back into the person's body, and suddenly it can do what it was failing to do previously, which is find the myeloma cells and destroy them. And that's why this is so effective and why it's so incredible, because it's a bespoke product, and by that I mean it's unique for every individual patient. It works beautifully in most patients, but it's tailor-made to that patient and their myeloma, and that's why it's so remarkable.
I mean, even when you describe it now in 2026, and I've been immersed in the field for a number of years, it still sounds amazing. I mean, it still sounds slightly ridiculous that, we have worked out a way to do this. So as you say, Sally, it really is changing those T cells that, before they're engineered, they're just, flying around our body doing, important things, stopping us from getting infections. But they'd see a myeloma cell and they would say, well, there's nothing here, nothing to worry about. After they have been kind of engineered to recognize it, it's almost like they can hone in on them. It's like, well, hold on, this shouldn't be here. And then it attaches to the myeloma cell and then does what it's supposed to do. And, just even 25 years ago, the types of drugs we were giving in myeloma were essentially, toxic chemicals that, if you're lucky, you're going to kill some myeloma cells, but you're going to cause a whole bunch of other damage as well. So it's an incredible technology. Sally, we're starting with the patient, and then they've got their T cells inside their body that we want to engineer. We want to make them CAR T cells. So how do we get them out? What do we do first?
Yeah, definitely. It's such an important question, because it's really hard to comprehend. So what happens is you essentially need to take those cells from the body and send them away to a specialist lab where they can manipulate them and change them so they then become these kind of like almost supercharged T cells. And to do that, it's rather like our podcast previously, Jam, when we spoke about collecting your stem cells. You're hooked up to a machine, and the blood is siphoned from your body. The lymphocytes, which describe the overall kind of class of cells that T cells belong to, are taken from the body and separated out, and then the rest of the blood's returned to the body. And it's this process that we call apheresis, which is where it's a fancy way of saying you're taking blood out of the body, you're doing something to it, or taking something off and then putting it back in. And then, the patient goes home and they carry on with their treatment in the meantime while we're waiting for the laboratory to actually process those special cells to turn them into these CAR T cells to then help control the myeloma. And so in itself, actually, this procedure of collecting these T cells and sending them off to the lab, it's not a big deal, is it, Jam, really? You just get hooked up to a machine and, it's done and dusted within a day, and you don't need to stay in hospital. There's very few side effects. It's very straightforward. I think that the challenge with CAR T cell therapy, particularly for myeloma, albeit that this will change in the future, is it just takes some time to make the T cells. And so you hope you're able to control the myeloma with our regular treatments whilst you're waiting for those T cells to come back from their lab once they've been, changed.
It takes about a month for that process of engineering your T cells. Of course, using myeloma as our example, if people are getting it for myeloma, it means that their myeloma has become more active and the myeloma is growing and causing problems. So a very important consideration is, well, what do you do whilst those CAR T cells are being made? You can't just sit and wait. I mean, you could, technically, and there are situations where maybe people just wait because maybe they have a very small amount of myeloma there. But as a general rule, it is recommended that people have what we call bridging chemotherapy. So this is, treatment that we give for a few weeks to try and calm down the myeloma, treat the myeloma, to reduce the amount on board and stop it from getting out of control for when the CAR T cells are available. Increasingly, we know that bridging chemotherapy is important because the more controlled the myeloma can be before you put the CAR T cells in, it can help make the early weeks a little bit safer potentially.
Yeah, definitely. It's such an important part of the pathway, that, isn't it? But Jam, it's always a few patients in the past have asked me who've received CAR T cell therapy if they're having bridging and it's working. Well, why don't you just carry on with that? Why do you then have to stop treatment, which is working? Because we don't do that in any other situation in myeloma, to then give the CAR T cell therapy. I don't know what you think about that point.
What I would say is that in the trials that have led to approval of myeloma CAR Ts, often the people that don't get the CAR T, so they are what we call randomized, or the coin has been tossed and they just get normal chemotherapy, they get that. So they, rather than just the chemotherapy for a month, they get that chemotherapy until it stops working instead of the CAR T. We know that there is a difference between the outcomes. The people who get just a month of bridging and the CAR T do better. So that's, I think, one way of looking at it.
Yeah, I definitely agree. So those trials have happened, haven't they? This sort of head-to-head comparison to just carry on with the chemo or have a bit of chemo and have your CAR T. And almost across the board, the CAR T comes out tops, doesn't it, in terms of how long it controls the myeloma for. But I think there's something really important as well for us all to remember is once you've had your CAR T cell therapy, if it is successful, after that, you're not on treatment. You're monitored. You might need to come in for other treatments like immunoglobulin to help support your immune system, but actually you're not taking tablets every day, you're not coming in for injections, life kind of goes on and people tend to really enjoy that time, don't they, when they're actually, it's like they've taken a step off the treadmill for a while those CAR Ts continue to control their myeloma.
Indeed, and certainly it's one of the big attractions of having this type of therapy for many people, when in the past they have been on continual therapy, monthly treatment, and as you say, that treadmill of continual therapy that we've talked about quite a lot, haven't we, Sally? But it can be very draining and has a huge impact on quality of life. Going back to the bridging, as a general rule, it may be somewhere between 4 to 6 weeks. It can be a bit longer while the CAR T cells are being made. At this point, we should just say for myeloma, there are 2 sort of approved CAR T therapies, and there are a number of trials also for CAR T in the UK and beyond, and certainly some of our listeners may be approached for CAR T studies. So it's a living drug, right? So they are making something that was in your immune system and then is engineered in a very specific way, and they do a number of tests on these engineered cells in the lab to give a sort of analysis of how well they'll think that these will work. So when these CAR Ts come back, before they are sort of given back to you, there are all these technical specifications that whoever has made the CAR T will sort of send to us, and we'll go through that. Okay, so each product is a bespoke. We talk about personalized medicine, Sally. I mean, this is in a way, one of the ultimate personalized medicines. So we need to know, does it look like these cells will multiply in the body? When they hit a myeloma cell, are they likely to release the different types of chemical that they need to kill the cells? So we'll get all of that information. And what we say is that we need, ideally, the drug to be within specifications, the cells to be within specifications to give. And if they're not, or just without, you often have a discussion with the manufacturer, and then you talk about whether you can give the drug or not. And in some situations as well, it's important to say you can't actually make the CAR T cells. The process actually fails.
Yeah, it's very complex. And I think we're still understanding, aren't we, as we go, as to why some patients or some samples may be successful and some won't be. But I just want to pick up on something you said, Jam. In terms of specifications, I mean, I tend to view that rather crudely, actually. It's just like how many CAR T cells are there to reinfuse? What kind of liquid are they going in? And I guess that's what you're referring to, aren't you? Is that how successful was the lab in making that product, and how much of that product, how many cars are there to actually return to the patient?
So absolutely, that's very important. And over the years of development, people have looked at giving different numbers and seeing how they work and how they then grow in the body. So absolute numbers also is very important. And also to get a sense with different lab tests of how they may work in the body. And you get a sort of whole specification framework. As you say, we're still not quite understanding it, but in certain situations, the process fails. Do we really understand why that happens? I think we're understanding it better.
Yeah, I think we're still very much in the infancy, though, aren't we, really, in this journey? I mean, I think the process can fail on lots of levels. I think there's a lot of hope around CARs, and I totally agree with that. And I'm sure you do as well, Jam. This is so exciting, this. But, when you start on that pathway, it's not a given that you'll necessarily get to the end of it, because, as you said, the laboratory may not, for whatever reason, be able to achieve what it wants to achieve. The cells, when they come back to you, may not be adequate to be infused. And even if they are infused, and by that I mean, put back into your body, it may be that for some reason these cells just don't control the myeloma as much as we'd hoped. This treatment does not work in everybody. And it's really important to say that, even though it sounds incredible, it works in most people, but not in everybody. Or so the cells may not stick around, or what we call engraft. They may not multiply in the way that we want them to, and the cells that are made may not be very good at targeting the myeloma. So there's lots of challenges in this pathway. But I think what you can also say is this treatment still works, in the clinical study suggests anyway, for the majority of patients, which is really heartening.
Absolutely. And sometimes you won't be able to make them because the actual product, people who have had certain types of treatment, their T cells, the starting kind of T cell, just may not be adequate or strong enough. They just don't work very well. So even if you put a new kind of protein in it to recognize the myeloma, it's still just unfortunately not a very effective cell. So that can be one of the reasons. And there can be just other factors related to previous treatments or specifics around the person and where those, T cells have come from. As a general rule, when people are picked within specifications, so cells that can be reinfused, is the thing that we normally see. So Sal, assuming we've got these cells, they've come back from whichever lab they have been engineered in, they're ready to give. Our patient has had a bit of bridging treatment and the myeloma has calmed down a bit. What's the process of giving the CAR T cells back? What happens?
So this is rather aligned to having a sort of a bone marrow transplant, really, what happens next. Most patients now receive something called lymphodepletion, which is a medical way of saying you have different types of chemotherapy to calm down the immune system as it is active within your body, the lymphocytes, before you put the CARs back in. And the logic behind that is it just helps the body accept them, and it gives them a chance to then hone to the bone marrow and to grow. And if you don't give that lymphodepletion, I guess the risk of failure of the CARs, of them sort of being rejected, is greater. And so you have this combination of treatments. Some drugs, often we give drugs called fludarabine or cyclophosphamide, for example. They just quieten down the body for a short while. This isn't a prolonged treatment. It's a number of days. And then a few days after that, the cells go back into the body, and then hopefully they take to the body. And by that, I mean that the body recognizes them as their own, albeit manipulated, and they therefore grow within the body. And as they grow, we see changes in the blood tests. We see the total number of these cells, which you can pick up in the blood test, the lymphocytes, increase. And soon after that, you anticipate they'll be doing their job, finding the myeloma and destroying it. And so actually that process of the lymphodepletion, the CARs going back in, is quite straightforward. But, and as we said with other drugs, as the cells grow in the body, the immune system becomes very active. These T cells can become very active, and actually your body can react to that with this phenomenon we've spoken about before called cytokine release syndrome, or potentially this neurological toxicity, which we call ICANS. Thank you for listening to the Myeloma Minutes podcast, proudly partnering with Myeloma UK. For more credible myeloma-related material and support, please visit the Myeloma website at myeloma.org.uk. That's myeloma.org.uk. Or call the InfoLine on 0800 980 3332, which you can find in this episode's description. What's been your experience of these potential side effects, particularly after the CARs have gone back in with the CRS and the ICANS?
The lymphodepletion is quite straightforward. Those drugs, fludarabine and cyclophosphamide, sometimes they can make you feel a little bit sick, but often that bit can be done as an outpatient. And actually, the day the CAR T cells go back, it's kind of a bit of a non-event, really. They get reinfused and people generally feel fine. But as you say, Sally, you want those cells to go into the body, to think, oh, I'm back home. And what they do is when they see the myeloma, they do important things. One of the important things is they expand. And this thing called CAR T expansion, which you alluded to, is very important, because you want your army to grow, and it can grow inside your own body. But now it has this kind of receptor that can hit the myeloma when you get that interaction of immune cells and myeloma cells, you can get inflammation and activation of the immune system. And this is something that we've talked about when we've done the podcasts on bispecific antibodies, because the process it's similar, but the way in which you induce the inflammation is slightly different. So, of course, with the antibody, you've got a kind of, if you think about an inverted Y or a shape of an antibody, that is bringing the myeloma and the T cell together. But with the CAR T cell, you've got the hook on the cell. So it's just the CAR T cell and the myeloma cell going head to head. And as you say, Sally, you get this inflammation. You get this thing called cytokine release syndrome, which can cause fever and low blood pressure, amongst other things, and can be pretty mild to, unfortunately, extremely serious. And then there's this other condition called ICANS, which is, again, an early side effect of this type of cellular therapy and is associated with inflammation, but that inflammation really affecting the central nervous system and causing a whole bunch of, what can be very serious side effects. Now, we're going to do, I think, a separate pod to talk about those two things in detail, because actually we could spend about 40 minutes talking about that. But what I would say is that different types of CAR T against different diseases cause different amounts of inflammation. Okay. And for the myeloma CAR Ts that are available, those early inflammatory side effects, you tend to see them within the first couple of weeks broadly, but actually it can be a number of days before you notice some cytokine release syndrome, and it can be 5, 6, 7 days, even a bit later. But in that time, when sometimes people are sitting there and really not much is happening, which is fine, you're getting expansion of the CAR T cells and priming of the immune system before you start getting these early side effects. Some types of lymphoma CAR T, and we look after these patients that can get CAR T on the NHS for lymphoma. Some of these side effects are much more dramatic and can happen more early, but it depends on many factors. How well the disease is controlled to start with, even how strong and fit people are coming into the transplant, the type of CAR T cell product you're giving, and also the underlying disease. There are many factors. The key thing is understanding when you're likely to get these side effects, and then using specific interventions, Sally.
Yeah, definitely. I mean, I think we are in a luxurious position to some extent in myeloma. This is really looking at the silver lining, perhaps. The technology with regards to CAR T cell therapy has been around for a while. Myeloma as standard of care has been somewhat late to the table in terms of being able to use these products, or certainly in the UK. But whilst we've been waiting for these authorisations to come through, or the trials to tell us that the CAR Ts are so effective, as you said, Jam, we've benefited from understanding these processes in other diseases. Lymphoma is a very nice example of that. And so actually, I think most clinical teams now have experience of managing these very particular side effects and reactions because they've seen it occur in different groups of patients. And we are very fortunate, I guess, that whilst myeloma patients are quite likely to get some cytokine release syndrome, it tends to be pretty easy to calm down, relatively easy to treat, compared to how other people might react to other types of CAR T cell therapy. And by that, I mean people with other blood disorders. We've gained that experience, which I think has been very useful, I hope, for our patients. And similarly with the ICANS phenomenon, that's where you get this sort of neurological inflammation that you spoke about. That can be quite common in other diseases. Fortunately, in myeloma CARs, it's quite rare. And if it does happen, it's a bit of a non-event in that you can treat it quite nicely, calm it down quite promptly, and then life goes on thereafter. So I think we need to have our eyes on these side effects, but not get too worried about them if they occur. Just know that your teams will know what to do with them.
So people are generally monitored very closely for 10 to 14 days after myeloma CAR T. Now, in lots of parts of the world, that will be as an inpatient. I think because there's increasing understanding of when issues are likely to happen. With technology and being able to monitor temperature and oxygen levels in the blood and other things very easily remotely, more people might have these treatments, not as an inpatient. As you say, Sally, we have good interventions to calm down the immune system and treat if people do get the cytokine release syndrome. And Sally, for those first 10 to 14 days, the things that will be, monitored a lot are temperature and blood pressure. And people will be asked questions just to check they're not getting confused. So there's this thing called the I-score that we've talked about before, where we ask what sound like extremely silly questions for people who are not confused. But when you do get a bit confused, I mean, it's amazing how actually it can be a very, very early indicator that there is some trouble brewing. And what is interesting is that all the people that I've taken through CAR T therapy, the last time they were in hospital for 2 weeks was for a stem cell transplant. Even though we spend a lot of time, talking about this will feel very different to when you had your stem cell transplant, which is essentially dealing with, the side effects of toxic chemicals on the bone marrow. People think they're going to feel the same, but actually the profile of the side effects is really very different.
Absolutely. It's a bit of a non-event, isn't it? I mean, not so, I think because the expectation is so great, isn't it? Oh my God, I'm going to get my cars. They've been made especially for me. There they are in this tiny little bag that goes in. It's kind of like, is that it? And particularly on the day that they're infused, people are often like, really? Are you kidding me? Are you sure that it's not just like, just a bit of water or whatever? And then the days following that as well, having had horrible diarrhea, potentially weight loss and hair falling out and all that business with a transplant, they get their cars and it just feels, I don't want to exaggerate this, but it's just not the same. It's just hopefully so much more straightforward for the majority of people.
It is great. I mean, your hair doesn't fall out. I mean, the journey is affected by a number of things, including how fit people are when they went into it, how well the myeloma is controlled, and potentially how much myeloma is on board. These things are all very important considerations, and we're learning more about this all the time. Sally, what about infection with CAR T at the beginning in those first couple of weeks? Is infection a big issue? I mean, it's certainly less of an issue than you see with a stem cell transplant.
Oh my goodness, without question, because the treatments that we give to people prior to the CAR Ts going in, that sort of, as we try and calm down the natural immune system beforehand, it's not actually that toxic. And then when the CARs go in, as we said, they tend to take quite nicely. And it's not uncommon for people to develop a temperature as part of the cytokine release syndrome you spoke about earlier, Jam, which is often, actually, that's what's driving the temperature. But it's also not uncommon for the doctors to also think this is probably cytokine release syndrome. But it's a temperature, it might be infection. And so people can go on antibiotics at the same time as treating this CRS phenomenon. But generally, again, people tend not to get too poorly with that. And often the antibiotics are given for a number of days, just in case, and then stop soon afterwards. Thereafter, the risk of infection is still there. It's still present, particularly if the type of CAR T cell therapy someone's had is latching onto this really important protein called BCMA, which is there on healthy immune cells, healthy plasma cells. And so people often need to be protected from infection thereafter with regular immunoglobulin infusions. But actually, again, it tends not to be too problematic as long as you get antibiotics if you have got an infection, and as long as you stay on track with your immunoglobulin, I would say most people in my experience have been fine. Would you agree?
The people that I've taken through, I think they've been chosen very carefully as well, and they've responded very well to bridging treatment. They've been strong and fit. So yeah, I mean, the experience I've had so far has been very, very positive. I think with anything in medicine, the more you do it, of course, the better you understand it, and you realize that anything in medicine can be difficult and come up with scenarios that you maybe didn't envisage seeing. But certainly that inpatient stay for a couple of weeks, can be relatively calm without too many dramas. I think that is certainly absolutely correct, Sally. When people go home, which is normally after sort of 10 to 14 days, depending on where you are, people will need very regular monitoring. Things that we really think about with the myeloma CAR Ts are, of course, Sally, you mentioned infection and minimizing the risk of infection. That's extremely important, and immunoglobulin replacement is very common for this group of patients. And after a length of time, that may be able to stop, maybe a year afterwards, but that's sort of continually reassessed. But something that's extremely important with the myeloma CAR Ts we have available at the moment is trying to minimize the risks of what we call neurological toxicity. So this is side effects associated with problems in the in the nervous system. So what do I mean by that? People can get problems with their nerves, for example. So what are called the cranial nerves that help us control so much that happens around the face. You can get sort of inflammation of those nerves, and that can be problematic. And you can also develop problems, and this tends to happen a bit later if it does happen, what we call Parkinson type symptoms. So Parkinsonism is when people walk with a sort of a shuffling gait and have trouble sort of starting and stopping. But this is not Parkinson's, but it's because of the effects of the CAR T, there seems to be some kind of symptoms which can mimic it. Now, I'm not going to go into any of this in too much detail, Sally, but what I would say is that, like anything in medicine, there's the good and the bad, and understanding why people get side effects. And there is really lots of very interesting work being done now looking at CAR T cells and how they grow in the body. And potentially, if they grow too fast, it's almost like they're too eager, they can get to the wrong places and start causing some of these sort of other side effects.
Yeah, definitely. And I think we're still understanding how we can then lower that risk, because this doesn't really tend to present itself until some weeks, if not longer, actually months perhaps after the CAR Ts have gone in. And of course, these are in your body. It's not like you can take them out and undo what you've done. They're now part of your body. I hope in the years ahead that we'll understand that piece a little more and what we can do to prevent that from happening or make it less severe if it does occur. It's a really, really important point. Can I just pick you up on something you said earlier, and just to make sure that we are on the same page here? So you've spoken about patient selection and how important that is. And of course, we think about patient selection as well in terms of our bispecific antibodies, which is spoken about in other podcasts, or our transplants. But I would say that patient selection is incredibly important. But arguably, in most people, because CAR T-cell therapy is pretty well tolerated, you don't need to be quite so rigorous, for example, as you would do with a transplant. With a transplant, there's a risk if you take someone through a transplant whose heart's not working well, their chest's not working well, they're a bit older, they're a bit frailer, that they could have a terrible outcome. Perhaps it's a little bit more grey with CAR T-cell therapy. You can offer this treatment to people slightly different from the transplant patient population. It's available to more people. Would you agree with that assumption?
I think there's no doubt that age is not like an absolute cutoff for CAR T therapy. And to be fair, it isn't for transplants either. But we know that there is a type of fitness that is crucial for a stem cell transplant and dealing with potentially very difficult sepsis, which is something that we really worry about. But because of the nature of CAR T, without a doubt, it can be offered to a broader group of people, assuming that it's available. For example, you look in the literature, you speak to colleagues. I mean, there are a number of people over 80 that have been offered CAR T therapy for lymphoma as part of standard NHS care. And certainly I would expect we would do the same for myeloma if it became more widely available in the UK.
Definitely, and that is where it is a little bit different. And I guess that's where, in talking to your teams and exploring if this is an option for you, is there a study open for you? Even if you are a little bit older and other things may not have been suitable in the past, you never know, this could be an option. So it's really worth picking up that conversation. In the UK at the moment, it still would be on a clinical study unless you have the benefit of private healthcare insurance. But in other parts of the world, who knows, it might be reimbursed. So do remember that. Different rules apply to different treatments, and this is definitely a different treatment with different rules.
Absolutely. So Sally, I think you've touched on an important question here, is that, and I think something the listeners will be thinking, it's like, why isn't it more available for our NHS patients?
And that's a real challenge, isn't it? I think we were hoping to get CAR T-cell therapy available here some years ago because it is available elsewhere, and people know about this. They want access to it. Some of the results look absolutely incredible. But I think the key part of CAR T-cell therapy is obviously that production piece. And as we've said, that is tailor-made to each individual patient. And there are a lot of people living with myeloma in the UK. To develop the laboratories, the infrastructure to be able to make those special products is just a massive step change, and it costs a lot of money. And of course, we know that Yeah, our healthcare system is not a bottomless pit of money. And so to have the infrastructure and the funds to create this for everyone who's potentially eligible is just a huge task. And I think that may have slowed down our progress in the UK. But it doesn't mean that we're not working on it. It doesn't mean that we're not going to get there eventually. And I think everyone in the myeloma community thinks that CARs will come. It's just a case of when and how to make sure it is equitable. Everyone who is eligible can get it, instead of it only being available for a few people because they happen to be fortunate, they live in a certain place or whatever it might be. It needs to be fair. It needs to be available for all those who are suitable for it. And that takes time.
No, indeed it does. I mean, I'm very pleased to say that we've just opened a clinical trial for CAR-T in Oxford. So that's going to be hopefully one way that some of our local patients will potentially get access to it. But more broadly, we do hope within a couple of years, we may be able to use it as a standard NHS treatment for, selected people. And as you said, Sally, it's one and then done in terms of it's not continual treatment. Now, it's very important to say people relapse after CAR-T therapy. Lots of people, unfortunately, relapse, but you do get control of the myeloma potentially for a significant length of time where you're not on continual therapy. And that offers a cost saving in itself. So, I do think there is a way forward.
I share your optimism, Jam. I think this will be coming. And I think a lot of our colleagues in the pharmaceutical industry are also working on these pathways and these costings to make it available as well. So it's a win-win for all. And of course, our Christmas podcast, I think it was Karthik, wasn't it, who arranged the whole idea of the in vivo CAR, where you don't need it to be manufactured outside your body. It all happens inside your body. And should that deliver and look as promising as the initial study suggested, who knows in the future, that could really make this pathway much more straightforward, because actually all the faff of making this product in a lab and putting it back in the body, that would just be obsolete. It won't be needed. But that's a little way away. That's many years away yet until I think those studies report out.
That's CAR-T 101. I think we've kept this intentionally quite top level. There's so many more aspects of CAR-T to get into and more specifics. And I'm sure as this year progresses and into next year, we're going to cover this topic in different ways. But Sally, we touched on how different the experience of CAR-T is compared to something like a stem cell transplant. So, I'm really pleased that, for the next podcast, we are going to have an interview with a patient who last year, went through CAR-T therapy here in the UK. And it's going to be, fascinating to hear, her story from diagnosis to where she is now.
Yeah, really looking forward to that episode. It's such a treat getting particularly patients on to talk about their experience, and hopefully we'll have more patient stories over this next year as well. But next edition should be a good one. So watch out for it, everybody. And so lovely to talk to you, Jam. It really always is. And what a great topic to cover. We got there eventually. So very much wish our listeners well. Have a good couple of weeks and watch out for the next one.
Thanks, guys. See you later.
This has been the Myeloma Minutes. We hope you found this week's pod engaging, interesting, and above all, understandable and genuinely useful. If you enjoyed today's episode, please follow the podcast and share it with anyone who might benefit, from your online support group, your medical team, to friends and family. And as always, if you have questions or topics you'd like us to cover in the future episodes, please do get in touch. You can find us at www.themyelomaminutes.com or email us at themyelomaminutes@gmail.com. And you can find us on social media by searching The Myeloma Minutes on Instagram and Facebook. Many thanks for listening, and we'll see you at the next one.